My my topic assigned to me by Ronnie was calcium-related stent underexpansion and how do I manage. The question that I ask is, does every underexpanded stent fail? And what I mean by failure is, does it come back with a TLR? Does it have a stent thrombosis? Or does it come back with angina of effort? So this is a case which was done in 2003, a right ostium, and we did a 1.75 rotational atherectomy. Following that, we used a conventional 3.5 cutting balloon in those days at high pressure. You can see that the cutting balloon fails to expand. The stent furrow stent, you can see the severe indentation at 18. Those are the days of the bare metal, and this is a bare metal stent. And anyway, this is the result we got, severely underexpanded, almost half the size of what we had expected. And 2018, we had the opportunity to look at this lady for the left side lesions, and the right is perfectly patent, just as we left it. So a stent looks well and good. Question is, does every stent fail? The answer is clearly no. Is every TLR or ST, is every stent thrombosis or every TLR that comes because of an underexpanded stent alone? The answer to that is no as well. So the question is, I have got, and I just had to, for the sake of this talk, I divided the talk into two areas. The underexpanded failed stent, a terminology that I coined, and just the underexpanded stent by definition that we use in imaging. And when I mean the failed stent is a stent which has come back to us with TLR, a stent thrombosis, causative of symptoms that continue. Calcium does remain the most important reason for underexpansion for all practical purposes. Now let's look at the underexpanded stent. This is a gentleman who came to us with angina, and we got a CT, and you can see the CT on the top left corner, and the angio in the right in the bottom corner. When you look at the CT, you see a very small speckle of calcium in that one location. The calcium score is extremely low. The angio, like a garden variety, most people would do this angioplasty quite well with a balloon angioplasty and a stent, and that's it. Fluoroscopy calcium, you could see around mild to moderate amount of calcium fluoroscopically. So I thought, let's get a 2.5 balloon, and once I get a 2.5 balloon, let's do an OCT. And that's the protruding calcium that you can see. My OCT images clearly indicated by the white arrows over there that there was this large eccentric calcium protruding into the lumen, a normal lumen on the other side. So we thought the stent is going to walk in, so the stent walked in, a 3/38. We can see that there's a little bit of a indent in the mid-segment of that stent. So we took a 3.5 balloon and dilated to 18 atmospheres. And to both the orthogonal views, our balloon appeared well expanded. So we did an OCT. And this is what the OCT showed. Despite our best efforts, our expected MSA is somewhere around 8.5. What we get is 4.55. So having looked at this, I said, what else can I do to improve this? The only device left now for me to try was an IVL. So we took in a 3.5 IVL at 80 pulses. What happens? This was the angiography before. This is after the IVL. Not much of a difference. And look at the OCT. I've improved the MSA by 0.2. So I'm not sure if I did any good to this patient using that IVL. I regret not using a rotoblader in this patient, for sure. Maybe a 1.5 and a 1.75. At 12 months, this man continues to do well without any symptoms, walks without any angina. So so he's doing well, and I hope that he does well going forward as well. Another lady, 83 years old, inferior STEMI, calcified LAD. The culprit lesion was the RCA, so we fixed that. The LAD looked thrombotic with calcium, so we used a laser, and once after the excimer laser, we put in a Wolverine. You can see the 3.0 Wolverine not expanding. We went in with the IVL 3.0 based on the IVUS images, and this is 1:1 IVL for the lesion there, and 80 pulses with the indentation still remaining. We went in with a 3.25 NC balloon, 20 atmospheres. We went up to 24, no change. So anyway, these were the IVUS images. And the images that we're talking about is here is the branch, and this is just beyond that diagonal branch. So this is where we're facing serious in expansion. And the IVUS-wise, I mean, it looks quite innocuous, really. But here we are, the same lady, we went in and put in a stent, expanded it, and we have a serious indentation right in the mid-segment, which looks worse in one of the views, looks worse in one view compared to the other. When we look at the IVUS, you see the MSA beyond it is 8.1 and 8.3, and right at the unexpanded segment, it's around 5.2. So the question is, this patient goes home, does well, continues to do well, walks around 5 to 6 kilometers per day, and she's a very, very active lady, 80. So the question is, how far should we go with chasing these unexpanded stents? So when you have an unexpanded stent, I think Ashok raised this question very simply just after the last case. In the first case, I ignored the clues, which probably prompted me to wanting to use a rotoblator, but I didn't. But even after the OCT, I should have probably pulled out a rotoblator, and that might have shaved off a little bit of calcium to get a better MSA. In case 2, the ELCA eased the burden of thrombus, made my imaging catheters go across, and therefore it should have been followed up with a rotoblator, but it wasn't. And I think both of these are rota regrets. The final MSAs were 4.7 in case 1, 5.2 or 5.3 in case 2. But what we need to do is do the best to improve the MSA within the boundaries of safety. And I think the boundaries of safety are very important when we're doing a procedure. We don't want to have a perforation. Rota might have worked in both these cases, but that means that you have to then use a second layer of stent and metal. And if the MSA is more than 5.5, I tend to leave this alone. If the MSA was less than 3.5, we could try to use a rotoblator, and we have done that in the past and achieved a better result. So the question is, we come back to our original slide. What happens to these stents when we have the failed stents? Failed stents. This is a person, we put in we've done a Taxus stent many years ago. He's come back to us with an acute coronary syndrome, severe LV dysfunction. You can see the occluded OM, which is at the site of a previous Taxus stent. I know that the images are not very sharp when you look at the fluoroscopy for the stent images, but we put in a little marker to help you understand the dumbbell of the stent there. That's the previous stent. And we tried to expand it with a balloon, and at 26 atmospheres, it just would not expand. So we used a rotoblator. And here, I must point out that when we use a rotoblator, it has to be gentle. You need to not undersize, but try to oversize sometimes. We used a 1.5, extremely gently. The idea is never to push it across. The idea is to just linger around the stent area and see if it does the job. In this, we realize that after approximately 2 minutes of rotoblator, your burr is not gone too far ahead, but even this much has done enough for the lesion. And here we have a cutting balloon now going at 12 atmospheres and expanding it completely to get this kind of a result. So this patient, what do? Rotoblator, 1.5 burr, go with a flextome, and then a DES. This one, I've presented this case before, a circumflex ostium. What did we do? We put in a flextome, cut open, and then we look at the IVUS. These were the days when we used the Atlantis Pro IVUS machine, which was the 40 megahertz. You can see that there was a crack of the calcium at that site. We thought that this crack was encouraging, that it would allow us to facilitate a good stent expansion. So we put in a 4.0 stent. This was the result we got. What we had is an unexpanded stent with an MSA of 4.3. We underestimated the eccentric calcium, and we really overread the crack in the calcium there. This patient came back 8 months later with ISR. What did we do? Based on what we found that time, we had seen protrusion of calcium through the struts, and these are those little cracked calciums that go within the struts and come into the lumen despite the stent. So we used a 1.5 millimeter balloon here, a rotoblator here, followed with a 2.0 rotoblator. After that was a cutting balloon again and a stent. And what happens with this, you can see both The right angle views looking great. You don't see any lesion, any under expansion on the iris. We've been able to get our cross-sectional area to around 10.2. So the question is here, we used a rotational atherectomy. We escalated the burr, got a better expansion, shaved off more calcium, and that helped us get the cutting balloon to expand well and a stent to improve our MSA. In this case, this is a right coronary artery. Many years ago, a cipher stent has been placed in the proximal RCA and in the distal RCA. And in that distal RCA, we have an unexpanded stent. Half of the stent failed to expand. When I looked at the operator notes, he'd gone up to 18 atmospheres at that time, and he could not expand the stent. Now, what happens now? This is how the stent looks. We did an ELCA first to the proximal, and because this was an acute coronary syndrome, we went in with the saline, but the saline would not cross the distal artery. The distal artery, we had to use contrast. We used contrast, got across, and what did we find? We find this is what the IBIS showed. The IBIS showed that it was a 3 millimeter stent that was placed, which expanded to a 2.75 diameter in the proximal half, but only 2 millimeters in the distal half. This was after and we had expanded now. We took a 3-year balloon and expanded it. This is the expansion. You can see the complete dilatation of that, and that is our final result. So here the strategy was using an ELCA followed by a cutting balloon. So the question is, the access device could be rotational atherectomy, could be ELCA at times. This is a left main case, just deviating from the topic. We put in a rotablator and did a classical cutting, a DK crush for this 1-1-1 lesion, which was heavily calcified into the circumflex as well. This was a final result. Our LED ostium showed a 10.9. A circumflex MSA was around 9.99. The ostium was 7.3. And the left main and the confluence looked good. This patient comes back in 3 years with an ostial circumflex ISR. We went in with a 1.5 burr again, and we used a 4.0 IVL, went up with a 4.0 cutting balloon at that time, and redid this bifurcation strategy to only improve our MSA, which previously we were okay with 7.3, but we had learned that that was not good enough. And in our mind, this is what is called as the defensive MSA. And we improved that MSA to 12.4 this time, and he's doing better. So this was the strategy. For these unexpanded stents, we could use rotational atherectomy. We could upsize the burr. We could then use ELCA or other technologies to get access and then do a cutting balloon or any NC balloon to achieve a great expansion. We could then use IVL. IVL would play a significant part in some of these unexpanded stents where there's more than 180 degrees of calcium. OP and NC is an option. I haven't used it much, but thank you so much.